Good afternoon, everyone. I guess it's been a long day for you, so I'm going to try and keep this relatively short and relatively simple, because I like things simple in life. And just to talk about a little bit, some of the things I think has been covered. I had morning clinic at Moorfield, so I couldn't get here any earlier, so some of this may have been covered already to some degree. But I'll try and keep it straightforward and answer any questions that Bertil's left behind. I don't agree with everything Bertil says, so I'm a bit of a maverick, but never mind. So one of the things is that when you come to oncology, and I think as patients, you've been diagnosed, but there's a lot of other things that happen in eyes, and you are rarities in the general field. So when we see a new patient, at the back of our minds, there's all these other things it could be, and we're just a small part. They range from, on the top left, moles and benign lesions, down to different types of tumours, primaries, secondaries. You can get inflammation in the eye, and you can get hemorrhage and bleeding in the eye for different reasons. And they all present with lumps and bumps. So our job is to try and work out what's a tumour and what isn't. When I was at medical school, it was one of the first things they teach you. It's an old saying: when you hear hooves, think horses and not zebras. What that basically means is common things are common, but rare things occur. So don't jump to conclusions. The classic in medical school is that you go to an exam and they'll put an X-ray on the screen and say, what is this? And you look at the first thing that comes into your mind and say, oh, I think that's a lymphoma. Or something rare. And they'll say, no, just go through the X-ray. This is a chest infection, So think, okay, common stuff happens. What's common in an eye? If you start working oncology, you think everyone's got a tumour. Everyone out there is affected. It's not. There's a lot of bland things that get turned up. Freckles, a little spot of pigment. It's quite, I've got a little pointer here, just here. There's other bits, little patches of faint pigment on the surface. It's nothing to worry about. This is a common thing. Bigger than that are nevi, little moles. So these ones are a little bit more structured, a little darker, maybe a little elevated, but still quite a bland look about them. You can get big nevi. So this is down in the corner, in the iris root. And then the picture on the right is with a gonio lens. So it's a little lens, a contact on the surface with a mirror in it. And then you can use the mirror to bounce the light and look into the corners. And what you find is the little mass there, it's just sitting at the edge, but it's not invading anywhere else. It's very localized to the eye. And you have to consider that's more likely to be a mole. Maybe it doesn't need treatment at this stage, but you certainly want to watch it. Melanomas, on the other hand, and Bertil's shown a few pictures as well, these are rare. Ocular melanomas occur, uveal melanomas in 6 or 7 per million of the population, and less than 5% would occur on your iris. So we might treat 2 people a year with this. They're generally very slow growing. They're usually low-grade tumours. They can take months, year to actually show definite evidence. And as Bertil said, the things we look for are what we call correctopia, where the pupil has got an odd shape to it. Ectropion, where the edge of your pupil is curling over. Glaucoma in one eye. Evidence of seeding or bleeding. And here's an example of an iris melanoma. You have a sort of a darker, flatter component, but there's a lump, a nodule in the middle. Here's the same patient with that gonio lens put in on the right side, and here you can see it actually, like a little mountain, sits proud. And interestingly, there's a bit of pigment in the edge, what we call the angle of the eye, where the fluid in your eye drains away. So if you've got pigment around it, a bit further on, that's a bit suspicious, rather than just being localized in one spot. I think anyone would look at this and say, that looks worrying. That shouldn't be there. We've actually got a pale mass on the surface. It's pulling the pupil into a funny shape, and it's got lots of little blood vessels in it. So I'd say, yes, I wouldn't biopsy that. That's a melanoma. And here's again another one, sort of a broad base, and then the mass with the blood vessels. We're treating a patient at the moment, a young man of about 32, who presented to clinic a few weeks ago now with quite a similar one to one of these. Quite a pale thing up in the corner. But 32, fitting well, you think, well, the odds are it's not going to be a tumour. So we treated him with some topical steroids, thinking it may be all inflammation at that age. So he had about a week of intensive steroid drops, but it made no difference at all. He came back to clinic, so we decided to do a biopsy. Took him to theatre, put a little biopsy pair of forceps into it, took a bite. As it came out, it started bleeding. And it bled, and the whole front section of his eye filled with blood. That put the pressure up. He spent a week in hospital trying to manage all the complications and get him under some control. And at the end of the week, when things were looking good, the pathologist said, I don't know what's that sample yet, but it's abnormal. And there are malignant cells in it. Then we went back to him and said, do you have any other symptoms at all? Anywhere else? Go through a sort of checklist, heart, lungs, bowels, skin, urine, anything. He said, the only thing I have is I've got a bit of a cough for the last 2 or 3 weeks maybe, but quite mild, don't think much of it. So we sent him down to X-ray, and they rang and said, there's something in his chest. They took him to CT at Bart's. He had an urgent CT, and he's got a large mass, and I think it's a primary lung cancer with signs of spread already. And then I had to break the news, 31-year-old, 32-year-old, that you've got metastatic lung cancer. And he's at Oxford because he lives near there, and they're treating him at the moment, but it's heartbreaking. And it looked like that. And you go, who would have known? I don't know if anyone's heard of a ring melanoma. It's one of the rarities. So the difference with the ring, sadly, is that the actual sort of primary mass may not be that large or that prominent. But the problem is it's growing like little tentacles, and they're growing in the angle, where your fluid drains. And then it sort of creeps all the way around. And then the pressure starts to go up. So what we say is beware of the patient who's got glaucoma in one eye. Most people, as you get older, you get glaucoma. It tends to be bilateral to some degree. But raised pressure in one eye only. We tell people, it's under the differential diagnosis. Don't jump to conclusions. It might be a hoof, but it might just be a zebra in this case. Choroidal nevi, very common. It's calculated that at least 5% of the adult population has got a mole in one eye or the other by the time you're middle-aged. If you take Asian people out and black people out, it's probably closer to 8 to 10% in Caucasians. So there's a lot of them. And every week we get letters from opticians and GPs saying, please will you see this patient? The optician has found something. But these are sort of the nevi, very bland, small, pretty flat. Another one here, just a little thing. So with nevi, we say they're common. They're usually quite flat or minimally elevated. And the chance of a standard nevus turning into a tumour is said to be around 1 in 8,800 per year. Hence, melanomas are still rare. And here are a few examples. So you've got one here just below the disc. Another sort of more bland, more atrophic looking thing, a lot of surface changes. And that's a little tail, which is suggestive that at some point it probably leaked a bit, and then it's dried up all by itself. So maybe a little leaky nevus at some stage. Bottom left is more diffuse, wider, flatter, and some are even relatively pale. They come in different shapes, sizes, and colours. I'm sure you're sick of death of watching melanomas now today. There's a lot of these. Berto talked about moles. And I think people spend a lot of time trying to find letters to make their things fit properly. So this was too fine, small ocular melanoma. And I think someone spent a lot of time getting those letters right, just to be able to say that. And we talk about this a lot. What are the risk factors? Thickness, is there fluid leaking out of the mass in the eye? Do you have the right kind of symptoms? Is there lots of orange pigment on the surface, which is a particular pigment that is a risk factor? And how close are they to the disc? Now, I trained with John Hungerford, and John used to say, the only three things that really matter are thickness, fluid, and orange spots. And he used to say 1 out of 3 is suspicious. Chance of it growing is about 10% in 10 years. This is personal experience. 2 out of 3 is very suspicious, because that would probably grow 30 to 40% chance in a decade. And if you have all 3, treat it now, because it's going to grow. So we've added 2 more from the studies and statistics, but I still think those are the 3 big ones. The UHH stands for ultrasound hollowness, which is what you see on a scan, and the absence of a halo. So some moles have a pale ring around them, and that is said to be a good sign. So not having it, it's like a double negative. Not having it is suspicious. So like I was saying, someone said to me earlier, it happens in men more than women. It does, by a little bit. And it seems to be the same wherever you are in the Western world. So we don't have any real evidence that sunlight is related to these things. If you look at studies comparing USA, Europe, Northern Europe, Southern Australia, where there's a lot more sunlight and UV levels, it doesn't seem to be very different. And the incidence of skin melanoma has doubled in the last 2 generations from sun worship, but we haven't seen it with eyes. It's grown with an aging, growing population, but there's no sudden increase to suggest why they'd be linked together. So we don't have proof it's sunlight, and I get that question quite a lot. Bertil said, symptoms of those kind of things, flashing lights in the eyes. It's all visual. Center vision, visual field loss, and about a third are found by chance. They've gone to the optician, they've had a photo taken, they've gone to clinic for something completely different, and they found a mass. And it's often the leaking, the detached retina that gives you most of the symptoms. Chap this morning has a 9.5 millimeter mass, but he's only had symptoms for the last 2 or 3 weeks. And that's because it's the detachment that's causing his flashing lights and the visual loss. But he doesn't realize that there was a mass in there. So a few examples. We have melanotic, which means pigmented. So it's a dark base with the mass in the middle that's growing, a little nodule. The right one is amelanotic, so without pigment, much more pale. And the ultrasound is this one down here, which probably many of you have had. So it's a scan of the structure of the eyeball. The left side is the front of the eye, the right side is the back of the eye, and that's the back surface of the retina, and then the choroid going outwards and sclera. And here there's this little mushroom shape, and that's very characteristic of melanomas in the eye. There's a reason why it happens, because it starts in the deep layers. It tends to grow up like a little mound, little hill, and then it pushes in the membranes above, in the layers of the eye, and it bursts through the membrane. And then it grows above it. So there's a big base, a narrow neck where it went through the membrane, and then a mushroomy shape. And that's quite characteristic when you see that. Ciliary body is anatomical. So this is a bit of the eye that's behind your iris, relatively hidden away. And if you dilate the patient out, you can see there's something behind it. But with a normal closed pupil, you'll miss that, won't see it at all. Sometimes, like on the left here, it'll actually grow forwards and come out into the iris, into the front compartment. So the patient was sent for this, pigmentation on the eye, but when you look in, there's actually something behind it, and the ultrasound will pick that up. Another one, so a bit in the front compartment, but actually there's a mass behind it, and it's pushing on the lens and pushing the lens forward and to the side as well. So there's what we call subluxation. The lens is shifted because the mass is growing. And the other interesting thing, people don't seem to notice it. And the chap today hasn't realised it, but it's very red on that side of the eye. Because it's basically the blood vessels have dilated to feed this tumour inside. And people don't see it. I said to the chap this morning, have you noticed your eyes redder on that side? No. Same again, mass at the front, got a dense cataract, so you can't really see behind it. But it turns out there is something behind it. Again, the big dilated blood vessels are a bit of an indicator that something might be going on. Sometimes it will try and get out, if it can, and we call it extrascleral extension, so through the sclera. It's found a little weak spot somewhere, and that's the tip of the iceberg. So other things that turn up. Everything is not a melanoma in the eye. Sometimes they are cancers from other places. I was late today, missed my morning, my train, because I had a patient who's been sent, one of these classic stories, had her cataract done, and no one really looked in her eye by the sound of things. And when they took the cataract out, couldn't realise why her vision is still poor. Then looked inside and found there's a pale mass in the back, and she has a history of breast cancer. And so this morning, it was sort of likely that what's in her eye is metastasis from the breast, and we'll treat it separately. But it is said the most common eye tumour is a metastasis. It's from somewhere else, not a melanoma. So things like this, lung tumours, classic breast tumours, so these are small, pale. They're often not very big, but they're very active. You get a lot of symptoms, a lot of leaking fluid out of them. So more of a large, pale, solitary one. This you might hear about. It's got a very long name, but we call it chirpy for short. And it's a very particular kind of mole. We think you're born with them. But when you're very young, they are really dark black in colour. And as the years and the decades go by, they start to change. Little white, pale patches will develop within them, and you get like a bullseye effect, a ring of pallor as the years go by. But they're moles, and they're extremely rare that these will change into tumours. And there's one on the optos, out on the large side there, with all the little, we call them, I think Latin, lacunae for lake, little patches of colour and the bullseye effect developing. Melanocytoma is another kind of mole, most commonly around the optic nerve. Very feathery looking thing. Also, we watch them, but they're very rare to turn into tumours and grow. We rarely have to treat them. I don't know how well this shows up on a screen. They are classic. In the old days, before we had internet, I guess, people used to fax stuff over. And then you get a paper saying, please, when you see this patient, I enclose a photograph. And what you got was a piece of black paper. And you can't tell anything on the photo. And what it is a hemangioma is a collection of blood vessels in the deep layers. And it's the same colour as everything else is. So you take a photograph of it, it doesn't appear. It's just like a bland sheet. I think you're born with them, and they sit there doing nothing for decades until the day it wakes up and it starts leaking fluid. And you get leaking and symptoms, and they get discovered. But they are benign. Hemorrhage, particularly in more elderly patients, people with AMD, people on aspirin and blood thinners, they'll turn up with a mass. Local hospitals say, I think you've got a tumour. They come to us, you think, well, it's an odd shape, it's got blood around it, you've got signs of macular degeneration, elderly patient, maybe on aspirin. Don't biopsy it, don't do anything, just give it a bit of time. Come back in a month. And if it's blood, it'll actually start shrinking. And if you do an ultrasound, you can look for blood flow in an ultrasound, and you'll often find there's no blood flow in this at all. So just give it some time, don't rush, and often it'll get better by itself. And you know it's not a tumour because it wouldn't go. It's an osteoma. So this is basically bone cells in the eye. Again, we think you were born with them. It's a developmental anomaly. But they've got this very pale, sharply edged, deep bit of bone tissue, calcified on an ultrasound. So some of the tests I'm sure you've all had done in your time. One is the ultrasound of the eye. So it's basically a high-frequency sound wave. It gets sent from the probe through your eyelid, through your eye structures, and it bounces back. It's like a radar for aircraft. And then you can look at the image on the screen. It's particularly good for patients where you can't, for us, we cannot look in the eye at all. It's full of blood, you've got a dense cataract, so we can at least get some idea of what the back of the eye looks like. It allows us to go hunt for things. You can take measurements out of it, but it's most commonly actually used in cataract surgery because there's a type of ultrasound called an A scan which measures your eyeball, the distances, and they use that to work out what kind of lens you'll have put in. That's our little machine. We've got a big one upstairs at Moorfields, which is the fancy one, and we've got our little Sonosite just down in the clinic. So it's just placed on the eye, I'm sure you've had, and then you look at the screen, and then we can take measurements, we can print them out, and put them in the notes. And these are the kind of things you'll see. So, you know, dome-shaped mass, and he's taken numbers to go with it. This chap is I think he's European, I think he's Bulgarian, who presents with hemorrhage and a painful eye with a lot of high pressure. And again, people are giving him drops, giving him tablets, and no one did an ultrasound. They can't see inside. But in fact, there is a large mass in the back. And he's had to have the eye enucleated and removed, just for nothing else, for pain relief, but also to find out what that was, and it was a melanoma. Some of you might have had this thing called a fluorescein angiogram or an ICCE angiogram. This is basically an idea of looking at blood flow in an eyeball. It doesn't have a lot to do with melanomas, but it's probably more help to tell what isn't a melanoma in that respect. But we give you an injection of some colour in the back of your hand somewhere. It goes through your bloodstream, and then you take a series of photographs over about 10, 15 minutes. So it's a time-lapse way of looking at blood flow within the eye. And then you can look at perfusion. You know, here we've got blood vessels, here it's all clogged up. Patient with diabetes, leaking spots, or weak spots in the eye. And the ICG is a different dye, a green-based colour, which is very good for looking at the deep layers, the choroid. And that's the choroid blood vessels of an eyeball. One of the questions that apparently I was asked was, what's an OCT? And does it replace a photograph? Say the optician offers you when you go to your clinic. And someone said apparently, my local optician said, oh, I don't have a photograph. We can do an OCT much better. So I thought, well, it's worth knowing. What's an OCT scan? It's basically a scan of the layers of your eye. So it's basically in the retina. So it's a sideways cut. So that is the retina, this little ribbon at the top. And then there's a bright white line, which is what we call the Brooks membrane RPE junction. And the choroid is the deep blood vessels. So in this patient, they had a scan of that quadrant, and then you can take slices, and there's a bump. And so you can tell it's in the choroid, you can tell where it is anatomically, and you can measure it. So it's a nice thing to have. It allows you to measure little things better than an ultrasound. It's got a higher resolution, and it helps to make diagnoses, whether they're tumours or not tumours. The problem is you only get a scan of a small area. So in this case, it's just that block. So there is no point having a scan of one little block of your retina in an optician's, for example, because they've got this new toy. You're just going to miss. What you want is a photograph, a wide angle, ideally a picture, and best done if you can be dilated. The modern Optos camera does a pretty good job even through a small pupil, but we will always dilate you and get a wide angle, good peripheral shot. So my answer to that question was, I would say no, have a photograph and have it with your eye dilated so you have a good view of around the edges. The problem is photography isn't perfect either. Now, you could look at these 4 pictures and think, okay, maybe there was something there, a bit more there. Now it's growing, and look, it's got darker. Must be a tumour. That is the same patient taken on the same day with 4 different flash settings on the camera. And high flash, it bleaches the picture, and a lower flash, it turns up, makes it look bigger. So even photography isn't perfect. And the other question someone said is, does stress cause cancer? And does stress cause ocular melanoma? Well, not directly. There's no proof that stress causes your tumour. And there are big studies that have looked into it. So one is, say, 2016, a study done on breast cancer in women, 100,000 people, couldn't find. And I think the difficulty is, how do you define stress? For different people, it's a completely different thing. But there's no consistent evidence they found anything. A meta-analysis, the term we use, is basically an analysis of lots of studies. So you should have a better answer by comparing studies and analysing them all further. There's another big study done 6 years ago looking at a whole host of different tumours. And they also found they couldn't find any evidence of stress between them. And there was a study in Denmark which actually looked at people with post-traumatic stress syndrome. And they found they seemed to have no increased risk of cancer compared to the general population. But I think the answer is stress leads to an unhealthy lifestyle. I think you smoke more, you probably drink more, maybe you overeat more. And I think it's those risk factors of lifestyle changes that indirectly increase the risk. But I don't think it's stress does it. Cause and effect. Thank you. If you have...
Thank you very much. Thank you for that really interesting talk. So hopefully that's cleared up some questions that we've had. But I do know that there are some more.
Yeah,
so they'll be up on screen in a moment. So if you've got any questions, please submit them. If you have one that you just want to share with us now in the room, then you can do. But it looks like they're going to be...
We had this in California with little hand apps. Yeah. Typing away. And by the time you could type it, they'd already finished. You couldn't send the questions in. So should you be dilated a routine eye exam by who? So I think if you come to an oncology clinic, we'll dilate you. Both eyes, whichever, doesn't matter what you've come for, I'll dilate you anyway and check both. If you go to the optician, I think it's good if you can. Maybe they all can't, but I think it's worthwhile because they will. Opticians, I'm lecturing them next week, an optometry course at Moorfields, and you are taught to look at the central part of the eye, so the nerve, diabetes, glaucoma, the general day-to-day stuff. And I think they don't always really look around the peripheries as a rule. So it's worth, if you can, get some eye drops in. It takes a bit longer, but it gives them a chance to have a sort of good look around. So yes, I would, if you could.
Is there any risks around dilating eye exams?
So there's two parts. One is the fact that they dilate your pupil. So it will blur your vision for a while. So if you have driven in, you may not be able to drive home again. And that may last a few hours, so you have to bear that in mind. The only medical risk is that if you have what we call narrow angles, so the front compartment of your eye is really narrow, there's a worry that as your pupil is forced open, we may block the angle bit, the drainage system, and we could induce an attack of glaucoma. They are really rare, though. So it's in every textbook, but I don't think, even in our clinics, I doubt we see like 1 every 5 years, a drop-induced acute glaucoma attack.
And is that reversible? Rare. Can you then do something about that? Or?
It is. There is a drug, I can't remember the name because I've never ever used it, but there is one drop you can use which directly counteracts it. Pilocarpine is the opposite of a dilating. It forces your pupil closed. It's like a bit like a tug of war, one drop pulling it open, one drop closing it. There is a drop that actually is a direct, I'm sure Morphus have got one somewhere, but I've never used it. No, it's never happened.
And I'm sorry, I'm going to ask another question as I've got the mic. Should somebody need a dilated eye exam more than once? So if there's no nevus, mole, nothing unusual going on.
Well, I would argue if you're going to go to your optician, you should do it anyway. It should be part of a healthy eye check. Do you really need it? I would hope you don't, in reality, but I think it's worthwhile doing. If I was going, I would say at least, with modern Optos cameras, you can get a wide-angle photograph. So if they're not going to dilate you, if they can take a good photograph, I go to my optician and I don't tell them what I do. they put the photo on the screen, and I say, what's that? What's that? And he says, no, don't worry, it's fine. I was like, okay. But I'd get something, dilated or a photograph from a modern machine. The old cameras only used to take 50 degrees, a very narrow field, and they're not very good for this. But the modern fancy stuff will do 200 degrees. So, do you have to do it every time? I think it's a good thing to do anyway for your general health.
Yeah, but can you just recap with me on this one?
Yeah.
You're saying to go to my optician, and if they use the camera, then I don't necessarily need to be dilated.
Depends on your camera. So a standard retinal camera, as they were very narrow pictures. So I would say be dilated. Only the modern Optos, like we have some of our pictures, allow much wider field. So modern Optos, you can get a decent picture without being dilated. But I would still dilate you anyway. It's worth doing dilated.
Yeah, I recommended a dilated eye exam to friends and colleagues, and they booked it in, and then they were talked out of having it at the opticians. They said what they had was good enough, and they didn't need a dilated eye exam. One of my friends was told it was traumatic, and the other one was told they didn't need it. So then, because I was kind of recommending it, go and get a dilated.
Yeah.
So you were saying it's a good picture. Is it good enough? Is it without dilation? Does it cover the whole eye?
No.
It doesn't.
No. An Optos camera would do a good job comparatively. A standard retinal camera won't. You'll just get a narrow little 50 field, just about the back segment of the eye only. And they're not going to take 20 pictures and try and cover the lot.
Just taking a small section.
Yeah.
Hi, sorry, just a small side note to try and demystify the fear of pupil dilation. If you have an anatomy that predisposes you to angle closure glaucoma, the ophthalmology clinic, it's actually the best place where it can happen to you, because you can have treatment right away. And so it will happen to you, either you dilate your pupil or not. If you read in poorly light conditions, you're also at risk. So it's the perfect place to have it, if you're meant to have it.
Yeah. So I've never had to do it personally. They are rarities, but yeah, it's quite right. If you do it in an eye department, that's the place to do it. Where are we? So risk to the good eye. Risk to the good eye from the treatment, presumably, or from the tumour. So the chance of you getting spread from one eye to the other, I think, is extremely rare. At Moorfields and Barts, we have only seen one documented case, which we wrote up, I think. So Mr. Hungerford, John, I think, started about 83. So between 83 and now, so 25 years, 35 years? Oh, God. We've only know of one patient. So I think from going from one eye to the other is very rare. I mean, vanishingly rare, I would hope. Does having one eye make the other one more susceptible? I don't think there's any proof for it. You may find, you are reliant on one, and I say to patients, take care, wear protective goggles if you're doing anything that's dangerous, gardening, hammering, drilling, contact sports, anything, just to protect that eye.
Sorry, that was my question. And it was just because somebody has been asking, does the eye take the strain, really?
Yeah. There's no proof that sort of using it more would do damage to it. I guess if you've got, say you need glasses, and you've got refractive error which isn't properly corrected, you may get more eye strain because you're just forcing that one. There's anecdotal evidence in patients who have amblyopia, a lazy eye. So you've treated the good one, sadly, and the bad one seems to have picked up a bit. And they come back to clinic a year later and you find they're a line better. A textbook says that's not possible. If you have a lazy eye, an amblyopic eye in childhood, the wiring is in place and you can't improve on it. But you see it in real life, just a little bit. And that there is something, even the unaffected eye seems to improve a little bit because you're forcing it to work. Does being overweight, isn't there a thing in the press at the moment over a company writing down obesity is bad as smoking? I think it does. You know, and I'm getting a bit fat myself, so I can't grumble too much. But, and I'm saying it's that lifestyle change. It's an indirect effect. And it's not, we know like smoking, drinking, we know they are risky things to do. I'm not telling anybody that you're too fat or too thin, that's not my problem. But yes, is the answer. More overweight, more sort of, what we like to say, beast overweight, the higher ones, it does increase your risk, just as a lifestyle choice.
Shall we can keep these questions
Yeah.
and come back to you
Yeah.
and get
Pete's,
answers back to the audience afterwards, if that's okay.
Absolutely.
Fantastic.
problem at all.
Okay. Well, thank you very
Thank
much for
you
your
all.
time. Thank you.
That's it.